Hi, everybody. I'm Alon Kahana. I have my own practice in Michigan, and I'm on faculty at Beaumont Medical School, the Eye Institute there. And I was asked to give this talk on short notice by Rich Allen, who was going to give this talk, and due to unforeseen circumstances, cannot make it. And it's actually harder for me to give somebody else's talk than it is for me to give my talk. But the reason he asked me is because he and I do have essentially the same approach, and we take care of adults and kids with facial paralysis in very similar ways. So that the ideas were easy for me to convey. But I will share with you pictures and videos, especially videos. Dr. Allen is very well known for his videos that demonstrate the technique very well, the way he uses it, and I can share with you some of the slight differences, very slight differences that I encounter in my practice. Everybody here is basically, or most people here are practicing oculoplastic surgeons, so if you have a question, just raise your hand. You won't bother me, it won't break my train of thought. And I'd love to hear your thoughts. So the title is Eyelid Blink Paresis, Why I Like Platinum and High. I'm not going to try to sell to you anything. And by the way, I am speaking obviously on behalf of FCI, but I'm not going to try to sell you anything. What I'm going to try to convey is that if you're going to use an eyelid weight, I think that you should use a platinum weight rather than gold, and you should put the weight higher above the tarsus, not on the tarsus, and I'll explain why. These are my disclosures. And I do research with multiple companies in the thyroid eye disease space because of the nature of my practice, but I'm not a consultant to any company in the thyroid space. Paralytic lagophthalmos is a failure of eyelid closure, upper eyelid closure, and it leads to corneal exposure. I don't need to belabor this issue in this audience. And the treatments for it, this is something that has gone back hundreds of years. How do you address? Because eyelid paresis is nothing new, and lots of reasons for it. And you can either do a static procedure, just make the eyelid heavier. But first of all, you could suture the eyelid shut, right? If you have eyelid paresis and you can't have closure, you can suture the eyelid shut. Second, you could put something that will weigh it down, use gravity, basically, that's the static approach. Or you could place a spring, and I think it was Dr. Levin in California who made a major push toward the use of springs. I think that the spring idea is a very good idea, but the complication rates are high. And so I'm not going to talk about springs. I don't really have any personal experience with springs other than twice in my career needing to remove them because they were extruding. The goals of weight placement are to improve closure. And again, you're using gravity, so the head needs to be up. It can't be laying flat. If you're in one of those tilt chairs with your head down, it's going to have the opposite effect. Just realize that it's all just weight. If you're on the moon, it's not going to work as well. And then there's the issue of retractors. What's the retractor? It's the levator and Mueller's muscle. And if those retractors are engaged, contracting, unopposed by the antagonist muscle, there's going to be contracture, and we'll talk about that momentarily. It also improves blink, and this is a very important thing for me. And many years ago, I did a study using high-speed cameras looking at the blink in these patients. And many patients who have a paresis, not the total paralysis, just the paresis, and you ask them to close their eyelids, and that eyelid goes slowly down, but at the end, there's no lagophthalmos. But when you ask them, you talk to them during the normal conversation, and they just don't have much of a blink, and that's why their cornea is so exposed. So I think it's important to assess the blink and to place the weight in a way that will optimize not just eyelid closure, but also their blink. Now, what do we want to prevent? Complications. We want to prevent exposure of the weight. We want to prevent it from distorting the eyelid, causing irregular astigmatism, causing any issues with entropion by pushing on the lash line and the margin. And then, of course, there is the complication of any implant could get infected, could lead to inflammation, etc. So those are all things that in any surgery we want to prevent. It's important that the implant that you use be MRI safe, because patients with paralysis, sometimes that's a result of a neurosurgical procedure, maybe a tumor, maybe a stroke, and they're going to need to have the advantage of being able to be assessed by MRI. So that's an important consideration. The timing of intervention. In general, most of these interventions are too late. The optimal time to place a weight is before there is contracture of the antagonist muscles, before there is shortening of the skin, before there is decompensation of the cornea. It's the same thing as corneal neurotization. I get disaster cases where the cornea is about to perforate or it's totally white, and we can stabilize things, but heck, it's a lot better if I can get that eye for corneal neurotization before the cornea completely decompensates or the corneal graft got rejected. And we'll talk a little bit about that, and I'll share with you Dr. Alon's and my views on the timing. So with early upper eyelid loading, sometimes you do it at the same time. Oh, this is not the talk that I just gave you. This is the previous version. I do not use a 1.2 gram. That's what Dr. Alon uses. Can we find the talk that I gave you? I actually prefer, in the clinic, I have different weights that you can stick on, and I'll stick them on, and I look less at the lagophthalmos, more at the blink dynamic. And I'm trying to optimize blink dynamic. Sometimes, especially if I'm doing this earlier, oh, very good. Oh. Here we, nope, that's, I'll just ad-lib. Sometimes the eyelid becomes ptotic when I put a weight that's significant enough, let's say 1.4 or 1.6 gram, and it's an older person and they have ptosis. I am not bothered by the ptosis. I'm going to fix it at the same time that I'm putting in the eyelid weight. You can't code for it, but you can do it, and it helps. This way I can both optimize the eyelid blink and fix whatever ptosis they have because they just have ptosis. So I am not afraid of the ptosis issue when I choose my weight. And I do not use dermal fillers. So never do dermal fillers in these situations. I will use Botox if I need to temporize. That I have done, and of course, tarsorrhaphies if I need to temporize, but I don't use dermal fillers. The weight options. There's gold and there's platinum. And they're the same weight. They're essentially the same thickness, the same shape, the same size. It's just a difference in material. And I used to use gold weight. That's how I was trained. And then I had 3 cases of really, really robust inflammation very early in my career at the University of Michigan. And I was talking about it with an ENT colleague with whom I was sharing quite a few of these facial paralysis patients. And she said to me, Jennifer Kim, who's now at Mass Pioneer, if any of you know her, and she said, oh, we've moved to platinum a long time ago. You don't get the same complications with platinum. And so this is not something new. We've known about it for a long time that gold can cause problems. And it's a type 4 hypersensitivity. 5% of patients really develop it. You can get dermatitis. 10% will have a positive patch test. A lot of us have a sensitivity to gold. I could speculate that it might be because we are exposed to, my wedding ring is gold. My necklace that my grandmother gave me when I was 13 years old is gold. and maybe that's part of it, that there is some exposure. I've never worn anything that's platinum. I know some people do, but it's actually hard to make platinum jewelry. The fashioning of it is very different. And I assume that FCI knows because they need to do different things for platinum, which is the reason that they're charging you more for the platinum is not because the platinum is a lot more expensive than gold. It's because it's actually harder to work with. Is that correct? Yeah. It's just very much harder to work with. It's much harder. It's physically harder. If you do use gold and you get a hypersensitivity reaction, there's no amount of steroids that will fix it. You end up getting such a fibrous capsule or a rejection and extrusion that it's going to be a mess. You actually need to cut in, remove it, and replace it. The other thing I want to convey is that even though initially the way I was trained is to put the weight, pretty classic, right on the tarsus, as I progressed in my career over the last 20 years, I've moved higher and higher and higher. And I'll show you why. My experience is the same as Dr. Alon's, and probably the same as some of yours. And it's because, well, it's easy to just expose the tarsus. You suture the 3 holes to the tarsus. I use Prolene. I don't use Vicryl. Many ENT people use Vicryl. And I was taking out the weights that they were putting in because they would start to extrude. The skin would get really thin. And there were all sorts of complications. I had 2 patients who've come to me with pain, corneal irritation because the weight was sitting right on their cornea. For too long, I've had patients come and complaining of astigmatism, and their optometrist just can't get their refraction correct. So even though the high approach, high placement is somewhat technically more challenging, I think for oculoplastic surgeons, it's really not that much more challenging. I understand why an ENT surgeon would say, no, I'm not going to do this. But for us, dealing with the levator and Mueller's muscle is really not that big a deal. It's what we do every day. You just need to think about it in that sense. You don't see, here you can, this is pretty typical. It's not uncommon that this is what the weight looks like. And this is a well-placed weight. It is working. It is doing its job. But the positioning is making it not be optimal. It's obvious. It's on the cornea. And I'm not sure how much longer it's going to last because the skin overlying that corner is so thin. With high, I need to make sure that I stay on time. With high, you have really, I've not had any exposure issues. It's easier to create a lid crease, easier to correct either levator retraction repair because you've had, let's say you've got the patient a year out from their paresis and now the levator has contracted. You can release it. You can't fix it. The levator is now contracted, it's scarred. But you can release it like we do for thyroid patients. Or if they have ptosis, you can advance it. You can easily correct lash ptosis. In these patients will oftentimes have lash ptosis because the orbicularis is part of what keeps the tone of the pretarsal and the muscle of Rheolin. And it's not uncommon that I get a patient who has this kind of a weight and I need to remove it and then I put one, same weight essentially, but platinum and above. Now, Dr. Alon finds that weight prediction is harder for him when he puts the weight up high, which is why he now just does 1.2 grams in most patients. I still do the weight prediction. I put the weight a little bit higher. Typically, they have some extra skin, so it will fold because it's a weight and it's attached. It's glued with a little strip to the skin. The glue comes with the pack of the sample weights. And then I look at the blink. That's the primary thing that I'm looking for. And once I get the blink that is pretty good, that's how I choose the weight. And typically, after surgery, the blink is almost what I saw in clinic. So I understand that the blink is not going to be exactly what I see in clinic, it's almost what I see in clinic. But here's an example of a patient who has a weight placed, most likely sutured with Vico, because I can't see the proline, but it's basically clear skin that you can see it through, and it's about to extrude. That's the low approach. I'm not saying that all of them end up like this, but this is not a bad surgery. It's just the nature of putting a weight in an older person who doesn't have orbicularis tone, has atrophy of the muscle in that location. You're not going to be able to fix the atrophying of the muscle because it's denervated. So here is, actually I'm going to skip this, I'll come back to it. I'd like to start with the adult. These are videos from Dr. Alon. So this was a tarsorrhaphy placed temporarily by somebody. And it's a lid crease incision. He opens the septum. It's exposing levator. Now, I might put the weight on top of levator, suture it to the superior edge of tarsus. I will do that. Dr. Alon, I don't think, does that. He prefers to always create a pocket between levator and Mueller's. And Mueller's in these patients is typically somewhat thickened and degenerated, and so it's not such a difficult dissection. He and I both do that kind of a dissection for our frontalis muscle flaps when we do a sandwich technique with the retractors in addition to the frontalis. So it's a plane that we are very familiar with. You put the weight in between the levator and Mueller, suture it into position to the superior tarsus, and then close. And I might adjust the levator, sit the patient up, make sure that I am optimizing both blink and eyelid opening, and then close. And now I'm going to go back. And this is a child. It's essentially the same technique, just the anatomy looks a little different. And I'll show you what this child looks like later. Dr. Alon has pictures of this kid afterward with facial reanimation and the weight. Can everybody in the back hear me okay? Okay. By the way, I use either radio frequency or monopolar cautery. I don't use the hot temp cautery. That's a trivial difference, just mentioning. So he creates the pocket. He will recess the levator because the levator contracts if you wait to place the weight. If you wait to place the weight. If you delay weight placement. Now he sutures it to the superior tarsus. And here is the levator muscle. He includes that in his closure to create the lid crease, but it is ever so slightly recessed from where it was before so that the eyelid is not contracted as much. When you have the patient look down, if the affected paralytic eyelid is retracted, it's because the antagonist muscle and the skin are contracted from having not had the antagonism with the orbicularis. And so you need to address that. Make sure that you never remove skin in patients who have paresis because they actually get skin shortening, anterior lamellar shortening as it is. So watch the upper eyelid and down gaze and pay attention to how their tissue contracts. Putting a heavier weight doesn't address the contracture. You actually need to recess the levator a little bit. So same thing as adults as pediatric upper eyelid weights, platinum, high, and as early as you can in order to avoid that contracture. It actually changes the way that their entire eyelid grows. It's just like blepharophimosis and congenital ptosis patients don't just have a levator problem, their entire eyelid is different. So here is a kid that Dr. Alon operated on. Obviously, he also had strabismus surgery and facial reanimation surgery, but that's the kind of result that you'd want. I don't have a picture of this kid blinking or with eyes closed, but you can see that the cornea is doing very well. There are papers on induced astigmatism. If you place the weight on the tarsus, you're likely to induce astigmatism, and in this paper, they measured 1.2 diopters of, with the rule, astigmatism. If you place the weight above the tarsus, you're not going to cause astigmatism. It's not in the cornea. Even when the eye is closed and the cornea goes up a little bit, it's not really affecting the cornea much. Especially with a kid who potentially is in an amblyogenic age group, that's really important. And then supine versus upright. You need to make sure that the patient understands that the weight only works if the head is upright. Could be reclined, like sleep on 2 or 3 pillows, but you can't be completely flat and expect it to work. So the take-home messages, is that you should do the surgery as early as you can, before there is decompensation, before there is contracture of the antagonist muscle and the skin. So early. Use platinum to reduce the risk of hypersensitivity reaction, and place the weight not on the tarsus, which basically any ENT surgeon can do. The added value that we can provide as oculoplastic surgeons is that we can put the weight above tarsus, either on the levator or between levator and mular muscle, and then make adjustments to the levator muscle to address either contraction or ptosis, whatever the issue is for the patient. And with that, I'm going to close, and thank you very much for your attention. And I'd like to thank Dr. Alon for putting much of this together and then asking me to give his lecture. So thank you. My name is Alon Kahana. I'm an oculoplastic and orbital surgeon in the Metro Detroit and Ann Arbor areas in Michigan. FCI Ophthalmics has the full range of products that I use as an oculoplastic and orbital surgeon. And that allows me to both create a relationship with the company and the reps, and we have a very good rapport. It means that it's easy for me to work with the hospital to get the implants and the devices that I need, and they really have a commitment to our field. So FCI Ophthalmics is focused on ophthalmology and oculoplastic surgery. It means that there are not divisions within it that are for orthopedics or urology. It's all ophthalmology. Every meeting that we go to, FCI is there supporting us. They support our trainees. They support our programs, and that ends up creating a very symbiotic relationship. I think that FCI products are innovative, and they are priced well to compete. When I need an implant or a device in the hospital, there's already a relationship. Oftentimes, the rep already has some things stocked in the hospital, so I can get, sometimes you think you know what you're going to need for surgery, but then the needs change during surgery, and luckily they have the alternative there. And so that's very, very helpful, especially with orbital reconstructive surgery.